My name's Tamara Keith and I'm a paediatrician in London, and I'm going to talk to you about preterm delivery. I'm hoping at the end of this talk you're going to know what a premature baby is, what we do to prepare for delivery, and to talk about prenatal counselling and what to expect on the neonatal unit, and a little bit of detail about the short and long-term complications of premature delivery. A premature baby is any baby born less than 37 weeks gestation, and you're extremely premature if you're less than 28 weeks gestation. So who needs resuscitation? Basically, resuscitation is decided at delivery, regardless of the gestation. And if you're over 32 completed weeks gestation, you generally only need drying and stimulation and very little actual resuscitation. At less than 32 weeks gestation, the doctor or midwife needs to be prepared for more active support. And at less than 28 weeks gestation, you would need to plan to intubate and assist ventilation and give prophylactic surfactant. So what do you do to prepare? Prior to delivery, you need to check the correct staff are present. With a premature delivery, you need to have a senior registrar present, and possibly even a consultant. You need to prepare the equipment. If there is time, take a history and definitely establish the gestation of the baby. If possible, talk to the parents and tell them what to expect, and also assess what their wishes are for resuscitation. Equally, if there is time, invite the parents to visit the neonatal unit. Ensure the delivery room is warm. And why I keep saying is if there is time, is sometimes a mother will come in labour at 24, 25 weeks and literally give birth within 20 minutes. Others may be in labour for a couple of days, and there may be longer to discuss these issues. So equipment preparation. You need to check you have air and oxygen source with a pressure limiting valve, and this is so that you can give what we call inflation breaths. So you're able to set the pressure, the inspiratory pressure and the expiratory pressure, to give long, slow inflation breaths, allowing the lungs to expand during the newborn resuscitation. You need to check you have various sizes of masks so that you can fit the very, very small baby's face. You would start the resuscitation on air and only use oxygen if really required. Check also that you have a bag valve mask device available, and this is just in case your fancy machines fail. You set up your resuscitator, turn the heater on, check that the timer works, and check that the air supply works and that the suction works. You get your intubation equipment ready, so your endotracheal tube, laryngoscope, and equipment to secure the tube. Importantly, you need to have a plastic bag. So at delivery, the premature baby is put feet first into a plastic bag. This needs to be ready and open and in the warm air under the resuscitator. So as soon as the baby is delivered, it goes straight into the plastic bag. And this is to prevent severe dehydration of the baby, and it forms basically a greenhouse around the baby. So it prevents evaporation of bodily fluids, and under the radiant heater keeps the baby warm. You need to have surfactant ready, so we give artificial surfactant down the endotracheal tube, and this is because premature babies are surfactant deficient. This helps with respiratory distress later. You need to check you have umbilical catheters ready, just in case you need them to administer drugs during the newborn resuscitation, and have the transport incubator ready and pre-warmed. Read the notes and take a history if possible directly from the mother. You're asking about maternal, medical and obstetric history. Has she had many premature babies? Has she been on any medication during her pregnancy? Is she diabetic? Does she have thyroid problems? And so on. The pregnancy history. How many children has she had in the past? Has she had her antenatal scans, and what did the antenatal scans show? Is there concerns about fetal growth? Are there any suspected anomalies? And what is the estimated weight of the baby? Importantly, is this a singleton pregnancy, or are these twins or triplets? And very importantly, what is the gestation? Because remember, at certain gestations, at less than 24 weeks, you generally would not offer resuscitation. And it's important to know what the parents' wishes are. The labour history. Is the mother in labour, or are they doing an emergency caesarean section for preeclampsia? Ask the midwives or obstetric team what the CTG is like. So this is like a trace of the baby's well-being, and you can find out whether there has been any concerns about this, as to slightly predict what the situation may be at birth. And what antenatal interventions have there been? Has the mother received steroids? This would help with the preterm baby's lung development. Has the mother had antibiotics for any reason? Is there a concern that she has chorioamnionitis or any other infection, as this may affect the baby? And has the mother been on any regular medication, for example a beta blocker, which may make the baby more prone to hypoglycemia? The risk factors for sepsis are important to know about. You're asking about maternal fever, so a fever of over 38 degrees is significant. Has there been any history of chorioamnionitis? So this is basically an infection of the womb. Has there been prolonged rupture of membranes? This would be a rupture of the membranes more than 18 hours before delivery. And has there been premature rupture of the membranes? And has there been a history of group B streptococcus infection, either in this pregnancy or a previously affected child? So with any of these risk factors for sepsis, it would increase your concern and increase the likelihood that the baby needs antibiotics at delivery. Very importantly, you need to talk to the parents, known as preterm counselling. So introduce yourself, explain that you're a paediatrician, not an obstetrician. So you're not in charge of the delivery, but you're there to look after the baby. And explain what you think might happen. So assess what they already know. What have they already been told? They may already have had a previous premature baby, or their best friend may have had a premature baby. Or remember, they may themselves be a doctor and know quite a lot, or they may know absolutely nothing. So ask what they're expecting and what their greatest fears are. Explain to them what might happen. There will be lots of people present at the delivery, both doctors, nurses and midwives. The baby will be very small. It's a serious situation, and not all babies survive labour. The paediatrician will assess the baby's condition at delivery, and the baby will need some help. Resuscitation will be given, an oxygen mask will be needed, and there may need to be a breathing tube and a special medicine called surfactant to help the lungs. Explain what level of resuscitation will be given. And what I mean by that is that at less than 26 gestation, we do not offer chest compressions or give drugs. It's merely respiratory support, and we assess how the baby goes from there. Explain that the baby will be put into a plastic bag and be put into an incubator to keep warm. What will happen after delivery? The baby will be admitted to the neonatal unit, and the baby will be in the neonatal unit for many weeks if very premature. What will be done on the neonatal unit? The baby will be in a warm, humidified incubator, and the parents can visit the incubator and visit the baby, and in many units can visit at any time. They may need to stay on the breathing machine, on the ventilator, or they may be transferred to something called CPAP, which is a little mask over the nose to help with the breathing. And this will depend on the gestation and on the response of the baby to resuscitation. Feeding will be an issue, and the baby may require what we call total parenteral nutrition, TPN, or donor breast milk may be available. It's very important if the mother wishes to breastfeed that she expresses breast milk at an early stage, and I mean in the first couple of hours after delivery. A brain scan will be done to look for any bleed in the brain, which can happen in premature babies. And then baby may have an umbilical venous catheter, which is a tube coming out of the umbilical cord to give medicines. This is a picture of a premature baby, and you can see that there's many lines going in and out of this baby. So there is an endotracheal tube, a nasogastric tube, a cannula, and an umbilical venous catheter and an umbilical artery catheter. And you can see that although all of these lines are present, the father is still able to pick up the baby and be with the baby. This is what we call CPAP, so continuous positive airway pressure. It is a little mask that fits into the nostrils and supports the breathing in the baby by giving a continuous airway pressure, keeping the alveoli open. And it is worn over the nose like this baby is and held in place by a special hat. The baby will be in a humidified incubator, so you can see that this baby is in a very moist, wet environment, and it's very, very hot. And this is to prevent the baby from getting cold and dehydrated. The short-term complications of prematurity can be respiratory, cardiac, gut, infection. So in the lungs, premature babies have immature lungs and may need oxygen for many months. They may even go home on oxygen and develop something called chronic lung disease. There can be cardiac complications such as a patent ductus arteriosus. The gut can be affected, and initially they may be given total parenteral nutrition, but they are at risk at something called necrotizing enterocolitis. And this is basically a severe infection and necrosis of the gut, which leads to death of the gut and may require serious surgery. Premature babies are more prone to infection as they have an immature immune system, and hand washing is very important to prevent transmission of infection from carer to child. Jaundice is very common in all babies, but particularly in premature babies, and they may need what we call phototherapy. And this photo is showing phototherapy. So the baby can have this in the incubator or just at the cot side, and it's a special ultraviolet light to treat the jaundice. And they wear these special sunglasses that this baby here has. The long-term complications of prematurity, most importantly, are neurodevelopmental. So the baby may have learning disabilities, behavioural problems, or cerebral palsy. And cerebral palsy is a disorder of posture and movement. They may have chronic lung disease, leading to a long-term oxygen requirement. And the important complication in the eyes is what we call retinopathy of prematurity. And this is commonly thought to develop due to oxygen toxicity. So if a baby has too much oxygen, may develop retinopathy of prematurity. But it may happen even if the baby has not had too much oxygen, and it's just a complication of prematurity. An EPICURE study is very important for neonatologists and paediatricians to know about when talking to parents about survival and outcomes in premature babies. It's a study that looks at survival and outcome after birth and before 27 weeks of gestation. It's been carried out twice so far in 1995 and 2006. The first study showed that survival was unusual before 24 weeks. And the second, more recent study has looked at survival and long-term complications. So basically, the EPICURE study has shown that at less than 24 weeks, few survive labour, and of those that do, few survive to discharge, and most are disabled. At 24 weeks, 36% survive labour, and approximately half of those survive to discharge, and a quarter have no disability. At 26 weeks, most survive labour, and over half of these have no disability. So as you can see, with increasing gestation, there is a better outcome, but still at 24 weeks and less, the majority will have disability. And these are my references. Thank you very much.